I think we should start as participants are actively joining the webinar for the interest of time. Uh, Good morning, good evening, good afternoon, everyone joining this webinar from all over the world. Um, my name is Frey Hewitt. I'm the Executive Director at the International Institute for Primary Healthcare in Ethiopia. Uh, so on behalf of the Institute and our collaborators, I would like to say welcome. So this will be our first uh, session on our newly launched webinar series on strengthening primary healthcare systems in low and middle income countries. We did another series months back on urban primary healthcare programs, and we brought experts and speakers from different countries, from different organizations to share their perspective. And we had a good turnout, both from Ethiopia and across the world. And we had an interesting discussion around best practices and the challenge around urban primary healthcare programs. And we had a lot of ideas and perspectives from our participants as well in those webinars. We also had one single bridging webinar that linked the urban primary healthcare series with the recent newly launched series. So this launched series will be happening for the next 10 months. We're gonna host this webinar series every month, and it primarily focuses on different topics around the PHC levers, PHC WHO levers around the health system building blocks. So yeah, that should be interesting, and we also are very excited to bring in speakers and different countries' perspective in this webinar series. So without further ado, I would like to invite our moderator for today. We have Dr. Krishna Rao from the Johns Hopkins Bloomberg School of Public Health, moderating this session. Dr. Rao has an extensive experience in primary healthcare systems, and he will also be including some of his perspectives from India during his moderation and discussions. So over to you, Dr. Krishna.
Thank you, Dr. Frewat. I would like to extend a warm welcome to everybody to this webinar on health workforce in primary healthcare. As you all will recognize, this is a very important topic, both for primary healthcare and for health systems more broadly. Let me begin by introducing our two panelists today. Our first speaker would be Dr. Asakit Samuel Cheru. He's the Director of Human Resources for Health Development in the Ministry of Health in Ethiopia. Dr. Asakit Samuel has a lot of important responsibilities there. He is working as Human Resources for Health Development Directorate Director. He is also in charge of the HRH development in the country. He leads the pre-service education, including health sciences education, standard development, quality training, specialization and subspecialization training in the country. He's responsible for overseeing the continuing professional development and the principal in setting standards for in-service training of the health sector and leadership incubation programs. Additionally, he's also responsible for planning, forecasting the health professional needs of the health sector, collaborating with local and international partners, and he's also part of the policy level decision-making process. So he comes to us with a lot of experience in human resources for health issues, and we look forward to hearing him speak. Our next speaker is Katherine Kane. Katherine is a technical officer with the WHO Health Workforce Team in Geneva, and her portfolio includes knowledge management, network engagement, community health workers, and COVID-19 human resources for health management. Before joining WHO, Katherine worked for the Red Cross movement locally, nationally, and internationally, and has held additional policy, humanitarian, diplomacy, learning, and emergency management positions in national government agencies and health advocacy organizations. So Katherine joins us with a different perspective, a more global perspective on HRH issues for primary healthcare. Okay, so with that, let me invite Dr. Assaghith Samuel to come and make his presentation. Dr. Samuel.
Thank you so much, and the moderator for your generous introduction. So good morning, good afternoon, and good evening, everyone. So I'm very delighted to be part of this important discussion, HRH in PhD. So my name is Assaghith, so I will go through the health workforce in primary healthcare system. My talk will focus on the outline displayed here. I will talk a bit on the country context, how the primary healthcare system is tied with the health workforce system, how the workforce structure looks like in PHC, some of the experience we had, the strategies we used in the way forward as a next step. So I think majority of the participants are from different parts of the world. It will be very nice for me to talk a little about our context. So Ethiopia is one of the countries located in Africa, in Horn of Africa. So we do have a population more than 150 million, and majority of the population, as you see, live in rural areas, which makes harder for the health system to avail, basic health services. And majority of the population ranges under the age of, and below 50, meaning majority of the Ethiopian population, I can say, the young people. These are, some of the basic information that I would like to display. So on the indicators, in the past 2 decades, actually, we have regarded lots of improvements in major indicators, especially in maternal mortality rates, infant mortality, and 5 mortality. In majority of the indicators, we have a good progress. We have got a good progress, but we have also actually lots of assignments to do in the future to progress well. So the life expectancy has increased from 61 to 65.8 years. So these are some of the data we got from the Ethiopian mini EDHs. So as you see the data, I think there are improvements in majority of the indicators. This is, the combined efforts of, the health workers and different actors in the health system. Coming to the main discussion of today, the primary healthcare is actually.
Sorry, a second.
Yes.
The slides are not moving, and please.
How about now?
Please make it full screen, and no, it's not moving for me yet.
Actually, it's moving for me. I don't know what's happening. So, okay. Can you share it for me, or?
Okay, I can do that.
So let me stop sharing it.
Which slide were you?
I think slide number 5.
Can you make it full screen too?
Okay.
So. It will be very nice if you make, the full screen, a slideshow.
Yeah, it's full screen now, I think.
Okay, perfect. So talking about, the major agenda of, today's session is the primary healthcare system. Based on, the WHO guides, they call primary healthcare as, one of the programmatic engine for realizing UHC, SDGs, and, other health-related goals. Primary healthcare is, one of the cornerstone for a sustainable health system. If we want to ensure a sustainable health system, we need to make sure that primary health care is, at the baseline and forefront level. The other one is primary health care is, it's critical to make our system resilient to different kinds of, public health emergencies. It also helps for proactive and early detection of epidemics, outbreaks, and the other emergencies. So primary health care, they put primary health care as a major component of, the health science system. Next slide, please. Next slide.
Yeah, I actually have gone to next slide. I think it comes a little late, so I will make it as early as some minutes. So I'm in slide 6 now.
Okay, for me, slide 5, still slide 5. I don't know if it's going for others.
Slide 5 for me too.
Yeah, still in slide 5. Yeah, slide 5 for all the participants.
So I think making it not full screen can help for that.
So
So
yeah, now it's coming, slide 6. So I think that one is the global context. So talking about the Ethiopian context, specifically our primary care system, the government and, specifically the Ministry of Health Ethiopia is very much committed to achieving universal health coverage through PHC. So we took PHC as, one of the pillars to achieve UHC and other goals. On the plan that we have developed last year, the Health Sector Transformation Plan 2, we gave high focus and emphasis strengthening and expanding health service within the framework of the primary healthcare system. The other one is actually HSTP2, the Health Sector Transformation Plan 2, also intends to ensure that all components of care and essential interventions are available at PHC level. These are, the frameworks that we are following to implement PHC in our context. The other one is our tier system mainly focuses in availing health services at primary, secondary, and tertiary level. So majority of the services are available at PHC level. So strengthening the management and development of health workforce is, one of the key priorities in Ethiopian PHC system. The PHC infrastructure in the past has expanded, enormously. So currently we do have, a coverage of nearly greater than 90%. In some parts of the country, the coverage is nearly 100%. So this shows the government is very much committed in investing PHC system. The other one is one of the core pillars here is the health extension program. So the HEP program, continues to make significant contributions towards improving, health indicators in the country. The other one is in our PHC system. As I tried to explain earlier, it consisted the health posts, the health centers, and the primary hospitals. These are categorized in our PHC system. So based on the guide, one health center is responsible to give support, guidance for nearly 5 satellite health posts. So they are expected to cover a catchment population of nearly 25,000. The health posts are, categorized based on the new health extension roadmap. The health extension worker, the nurses, the midwives, others are, and some other basic health services are also included in the health service modality in our health posts. The primary hospitals are, expected to give service for both inpatient and outpatient services. They are expected to cover catchments nearly 100,000 people. Next slide, please. So why is health workforce important? Because when we are talking about the PHC, the important pillar is the health workforce. So it's obvious that, and I think everyone in the world agree that there is no health and security without health workers. If we are, there to provide quality health services, if we are there, to provide, to manage different kinds of public health emergencies, outbreaks, pandemics, we need to have, a strong health workforce. So health workforce is, it's fundamental and critical to ensure access to health services during, pandemics, emergency, and at the regular times. It's also, the health workforce is also very important for realization of universal health coverage and sustainable development goals. So health workforce is, critical, in our PHC and other health service modality systems. Next slide, please. So the primary healthcare workforce looks like in our country, in our PHC system, as I just tried to show you the tier system earlier, majority of the PHC services are covered by, the health care providers. So the health workforce at PHC level, play a pivotal role in improving access in quality PHC for the population. In our context too, when we say PHC workforce, there is no dedicated health workforce. Instead, it encompasses all occupations of health professionals responsible for organizing and delivering PHC. So we would believe that a competent, motivated, and equitable distributed PHC workforce, help us to deliver high quality PHC at all levels of the tier system. Next slide, please. In our PHC workforce, it encompasses all professionals, but we have the health extension workers who are, at front line for PHC service provision. The health extension workers, help us to live community and, to community and the health care services. They are there to promote good practice and, they are bridge to promote healthcare service in our context. So the contribution of the health extension workers in improving the PHC service in our context is very important and, very enormous. So most of the indicators have grown due to the unwavering activities done by the health extension workers in our context. So we give high value for our health extension workers. Next slide, please. This is, the stock and distribution of the PHC level in our context. So as of 2020, majority of the health workforce, works and lies, at PHC level. So as you see, the trend, the PHC level workforce, accompanies more than 80%. This is, our stock and distribution of the health workforce. So what do we have are the best experience and strategies in our context? Currently, the government, as I said earlier, we have designed a new health sector transformation plan too, which we have started its implementation last year. So as, a core agenda, we have put MCC, which we call it motivated, competent, and compassionate health workforce as a major agenda. So it focuses on, motivating the PHC health workforce, increasing the competency and the capacity of the PHC workforce and making more, the PHC health workforce, compassionate and responsive to the health system. So for that to happen, we have designed a strategy which will help us to guide its implementation in the upcoming years. We have also reviewed our national human resource for a strategic plan, considering the different developments in our context. We have developed essential health service package, the health extension program roadmap, also designed, in response to improve the PHC level activities and PHC level healthcare services. The other one, we do have an institute responsible, to share the experiences, the knowledge from our PHC system to the global. So that's the PHC Institute, which is responsible to do all these things. We do have different initiatives and others which, help us, the PHC system workforce, to be responsive to the PHC services. So saying so, we do have also challenges, as it's also, common in most, parts of the country. The first one is, the financial capacity is, is one of the challenges we are facing. We need an ample number of, human resource in different kinds of categories, but we do have, shortage. Our physical capacity is not enough to support the produced health workforce. That's one of the challenges which helps us, which challenge us to make resilient the activities in our PHC system. The other one is the geographic distribution and the mix of health workers between urban and rural is also the other challenge. Majority of the healthcare providers, the PHC providers are found in urban areas. So when we go to rural areas, the distribution is not expected and standard. That's one of the challenges. The other one, the capacity in HRH planning, management, and development, especially in where the zonal levels, in lower administrative levels, the capacity is limited, which hinders, to forecast, for proactive planning of the PHC health workforce. The other one is it's also because we do have shortage of the health workforce. It's below minimum SDG index threshold, put for low and middle income countries. These are the challenges that we are facing currently. As a way forward, we have actually making different kinds of, conversations that to promote the challenges that we are facing. The first one is the political will is very important. So we are trying to force, the government to make adequate investment for health workforce financing. As you know, in most parts of, especially in low and middle income countries, majority of the countries didn't allocate budget that was planned to be, put in our health expenditure, which is nearly 50%. So we are planning to increase our regional and national health expenditure to reach up to our budget target. The other one is we need to invest between nearly 50 to 60% of health workforce employment, remuneration, motivation, and other aspects of the health workforce development. We need to optimize the health workforce distribution, the retention, the motivation are very critical aspects that we have started different kinds of activity and we will strengthen furthermore in our upcoming years. The staffing norms need to be revised. Beyond all these things, we need to support our health workforce planning management systems through evidence. For that to happen, we are trying to strengthen our human resource information system. We have started the National Health Workforce Account and our labor market analysis workload and staffing need assessments are on progress. This helps us, to overcome some of the challenges that we have faced in our implementation during the past years. As a good step, I can say, we have actually adopted a resolution last year in the 74th World Health Assembly. So the resolution mainly focused on, improving protection, safeguarding, and investing in the health and care workforce. So this resolution, helps, mainly highlights to provide equitable access to vaccines, therapeutics, and diagnostic for all healthcare workers, to support decent work, education, recognition for our healthcare providers. And it also focused on, coordinating national workforce investment as a big agenda and action plan. So finally, this resolution is currently on table in WHO. So we have started developing an action plan. So the action plan will also help us, to further negotiate with different partners to have resources to support our health workforce development in IPHC system and in all the entire health system. So finally, the last slide, please. These are, the basic concepts and points that we are working with the global team. The first one is protection. So we have, a moral obligation to protect our healthcare workers, not only during emergencies, but at any time, when they provide services. So the COVID-19 pandemic has taught us lots of things. So we need to work on, protecting our healthcare workers. The other one is investment. Mobilizing investment towards healthcare and healthcare workers is very critical. This will be, the agenda that we will promote here in the country and globally to attract investments for health workforce development in other aspects of, health workforce aspect, remuneration, motivation, and other things. Together, this is, the final thing. We need to increase the dialogue, the intersectoral collaboration, the communication to sustainably, grow our HR's capacity to invest on prioritized healthcare systems, so healthcare facilities, and this will, finally helps us to ensure and realize universal health coverage and SDG achievements. So we are very much committed to support in this regard in the upcoming years. This is all about what I have for you. Thank you for your attention. Thank you.
Thank you, Dr. Assaghir. That was a very interesting talk. Let me now invite Dr. Katherine Kane from the WHO to make her presentation. And a quick note to all our participants, please feel free to post your questions in the Q&A. We'll come to those after Dr. Katherine Kane's presentation. Thank you.
Okay, always something to be said for speed and moving all the dials on your computer. Thank you so much for your kind participation today. I'm very excited to speak to you on this topic, although the way I start may be a little bit interesting. Among other elements, what you'll notice is I follow a bit of a format that journalists do when they are explaining something or looking at an issue, which is what in my parlance you look at as the 5 W's and the H. So it's who, what, when, where, and then the last W is why, and then we have how. So on that point, what is the PHC workforce? We in the Health Workforce Department and in Human Resources for Health don't actually use this term since it doesn't correspond to a specific occupational group. And these occupational groups are defined by the International Labor Organization and have specific classifications. That said, the need to invest in a PHC workforce is not a new concept. 44 years ago, or 43 and a half, if I guess you look at when Alma-Ata happened, the Declaration of Alma-Ata defined this concept of multidisciplinary PHC workforce. And what it tends to consist of is occupations with less than a 48-month education pathway. Today, this is still relevant. In fact, today, this is more relevant than ever as we look at population needs and we look at what is indeed, what are the services that we're looking for in our health and care workforce, and in fact, who are they and what are they doing? So they're engaging in health promotion, disease prevention, treatment, rehab and palliative care services, the public health workforce, and addressing the social determinants of health. So in addition to these health workers who are among the primary care services, we also have, and I hope that you'll look specifically at the icons that I used here, volunteers, care workers, and managers. And I think there's probably somebody in here who's already noticed what we've got when I have labeled the volunteers and managers. Anybody knows gender? There's a reason for that. Not only are 7 in 10 health workers women, but the greater majority of volunteers and care workers and unpaid care workers traditionally are women. Managers traditionally are, there's your icon, they're men. So this is part of our thinking, this is part of our investment, and this is part of our strategy. So when we look at getting to using PHC to achieve UHC, to achieve the SDGs, and I'm sure we can come up with some other acronyms there, but when we look at this investment in health, primary, what is primary? Primary means at the base of, the most important. And the most important thing that we're looking at is investing in the health of our people. And what does this actually mean? Does this mean that everybody gets the same thing in every country? No. What it actually means is aligning our planning and strategies, whether that's health workforce or one of the other 14 operational levers in the PHC operational strategy, that is aligning all of our plans and strategies with the population we're serving, with the community health needs. It means looking at our occupational groups and optimizing the tasks and roles. There are some old ways of looking at this that might call it task sharing or task shifting, which neither offers the respect nor really talks to the goal, which is ensuring that the right health worker is performing the right functions, that we have enough of those health workers performing the functions, and in fact, that they have the competencies and skills to do this and are supported. And it's also building this UHC, this PHC workforce means that we're building a workforce that can evolve to meet growing and changing demands. And this is anything from what is sometimes known as the youth bulge to increasing needs for care for non-communicable diseases, whereas some NCDs used to be deadly immediately. Medicine is advancing so quickly that we have a lot more need for palliative and rehabilitative care and a lot more demand. And all of these needs are varying by countries. And I think it's quite obvious that we also have something that could in fact be called right now the epidemiological, social, and political example of COVID-19. What I'm going to talk to you about, what I am talking to you about, hasn't changed, it's amplified. And if you look at the operational framework for primary healthcare, it says an adequate, well-distributed, motivated, enabled, and supported health workforce is required for strengthening PHC and progressing towards universal health coverage. So let's talk about some of the background and challenges. We know that health workers are critical to ensuring the right of health of all people. Why? They're the essential component. You can't, there is, as in fact, Dr. Ossigan said, there's no health without health workers. Our Director General is very fond of saying this as well. But if we take the people out of this, and you'll hear some echoes in my conversation about people, if we take the people out, we're not only not representing the populations that we're serving, but we're also taking out the essential lever in delivering medicine, in delivering services. This is also one of the interesting areas is that health is a large and growing sector for employment, and women comprise 67% of those in health, we use the figure 7 in 10, and obviously these figures change by year. But investment in the health workforce, and this is investment. When you put money in and you get something out that is greater than the sum of what you put in, it's a best buy to deliver returns across the Sustainable Development Goals: poverty elimination, good health and well-being, quality education, gender equality, decent work and economic growth. And in fact, I could happily name a number of others. I could make a number of different, pull out some threads within each of the SDGs where we can really look where the health and care workforce is delivering. But we have challenges. What are these challenges? Global shortages and skill mix asymmetry. So we aren't developing the right mix of skills among our different occupations. Mismatches between supply, need, and demand, rigid regulations, maldistribution between and across countries, migration, which is a really intriguing issue that is that's not simple, but also is possible to regulate and to find equitable solutions. And then we have, when we get to the health workers themselves, variances in the quality of performance, resource and environmental constraints where they're working, as well as regulatory failures when we look at what health workers can do. And I noticed that there are a couple people on here who are working in vaccination. It's a really interesting area that we're looking at in regulation, particularly with the COVID-19 vaccines. So what were the challenges? Chronic underinvestment in education and training. I remember before I joined the health sector, wondering about these CEUs. Why do they need to keep studying? Well, health changes, health needs change, approaches to health change. And in fact, Dr. Essegid mentioned something quite important, which is compassionate and respectful care. And when we're looking to gain the confidence of populations and to convince them to pay attention to their own health and to seek care, you really do require compassion. But is that a skill and competency that we're nurturing? Good question for you as you're designing your strategies. Mismatches in education and employment strategies to meet the health system and population needs. What does that mean? That means in some countries, they think we need to solve our health crisis. We're going to create doctors. We're going to create a lot of doctors. We are going to invest heavily in creating doctors. Now, don't get me wrong, doctors are wonderful, very, very fond of them. Without the complementary interdisciplinary team, it's very hard to deliver primary healthcare services. So we have to look at working with educators, working with education ministries, and working with labor ministries to define how we can have the right match of a workforce to meet the needs, and all of this within X fiscal space, and how we can then grow that fiscal space based on smart strategies. Lack of public financing to absorb workers. So in some countries, there's underemployment of health workers because there's not sufficient money to employ them. But this is at the same time as population needs aren't being met. Good strategies can change this. Rural and remote deployment. I doubt there's anybody on here who isn't facing that challenge. I grew up in a high-income country, and getting health workers into my small rural area who stayed, who were motivated, and who are applying innovative approaches, very hard. It gets harder the further you get. Migration, as I mentioned, inadequate gender representation in planning and leadership. We had a really interesting report led by a colleague of mine recently that looked at the number of women, and remember that 7 in 10 figure? And in fact, in nursing, it's 9 in 10. Nurses, 59% of the health workforce, 9 in 10 nurses are female. What is their percentage in leadership? Sometimes 25%, sometimes 20%, often less. What does that mean? It means the equities of those workers aren't being represented. It means the knowledge of those workers isn't being represented. And often the populations they serve aren't being represented because they're not sitting in the planning and leadership conversations. We've got to change that if we want to do better. Now, everybody knows this 18 million more health workers. That number, I want to tell you, that number is highly likely to change because of the COVID-19 pandemic. Why? Well, number one is that we've got changing epidemiology, going back to the last issue. when we have changing epidemiology, changing social needs, we have changing needs for health workers. What else? We've got a global scramble for workers. Regulatory changes in health worker supply, modes of service delivery, who can do what? I had the great privilege of publishing with a strong group of partners last year, a guide to the use of community health workers in COVID-19 vaccination. Some of the issues that we looked at were, what do the regulations say about what services can be delivered by whom and where? Concerns, and we have a lot of concerns on the impact of COVID-19 on the health and care workforce itself. So we started with workforce shortages. Then we have redeployment to respond to COVID-19. We have protests and strikes due to unfair working conditions, unsafe due to lack of personal protective equipment, lack of IPC, lack of occupational safety and health, lack of payment, lack of overtime. We have infections of health workers, which were extraordinarily high in the beginning of the pandemic, and thanks to a lot of good attention, have started dropping, but they haven't dropped fully. We have deaths. The WHO and the International Health and Care Workers Steering Committee put out a paper in September estimating that, well, the estimate was that no fewer than 115,000 health and care workers have lost their lives due to COVID-19 in the first 18 months. That number is going up. Deaths never go down. And as we're going through the COVID-19 response, we've also got new requirements for vaccination. We've got service departures because our workers are exhausted. Their mental health needs aren't being met. They're facing discrimination, stigma, violence, harassment in the community, and sometimes in their places of work. All of this means reduced access to services in the short and medium term, but it has even bigger consequences, even more frightening consequences when we look at our long-term needs, especially for delivering primary health care. So what do? We vaccinate health and care workers as a priority. We ensure a decent work environment, pay, safety, equity, social insurance. We allow students to complete their education. A lot of countries, and this was within the guidance that we put out on how to respond to surge needs, but a lot of countries brought back retirees or brought up students. Now, while it's good for them to get practical experience, they also must complete their studies. Studies and education were designed to create health workers who are able to respond to needs. And we need to include women and ethnic minorities better. I'm going to go quickly through these, and I believe that the moderator and the organizers will be able to share some of these. And I think I'm getting close to time. Hi, Krishna, I hear you. Yeah. So what do we want to do? Optimize. I'm going to give me 3 minutes and I'll walk through and then offer this as a resource. Deal?
If you can do in 2, that'll be perfect.
Well, now you're challenging me, but I'm standing up to this. Optimizing performance, quality, and impact. We had the global strategy on human resources for health. This remains our strategy. Align investments in HRH. Build the capacity of institutions for effective public policy stewardship, leadership, and governance. Strengthen data. You can't manage what you can't count. Tailor strategies to the country context. Establish national health workforce accounts. Conduct a health labor market analysis to inform how you're developing your health workforce, to understand where you should set the pay scales, because health workers should be paid. Target quantity, competency, distribution to a multidisciplinary primary health workforce. What does this mean? They're effectively managed, they're supervised supportively, and they're given appropriate compensation for their work. And so there are pathways to improve the availability and distribution, the productivity and performance of the existing workforce, to use a skills mix, to create linkages to the social services and care workforce who ensure continuity of care, and to harness the potential of community health workers as part of these teams. CHWs are my people. Partnerships. We need partnerships. We need intersectoral partnerships that leverage everybody's capabilities, that don't look at jealousy or rivalry or competition, but rather look at synchronicity and sustainability of investment, and look to where each partner can devote their resources in the best possible way. Speaking of resources, here are some awesome ones. We have many more, but here's some basics. This Building the Primary Healthcare Workforce of the 21st Century was the paper that we put out at the at Astana in 2018, along with, by the way, the WHO guideline on health policy and system support to optimize community health worker programs. My baby. Please don't ignore it. It is quite important to look at where all workers can contribute. Community health workers are a very important element of that, in alignment with the rest of the health and care workforce. These were the objectives of 2021, the International Year of Health and Care Workers, driving toward, and I hope you can see my cursor here, the Global Health and Care Workers Compact. What is this? You'll see at the World Health Assembly this year, comprising 4 domains and 10 areas of interest. We are creating for states a repository of international legal instruments that they can look at for direct policies, strategies, and management options to strengthen and support and protect their health workforce. I really look forward to speaking with you about this. It's something that we've been working very hard on, and we have some amazing national support for this objective. And we really look to the whole of society to help us move this Global Health and Care Workers Compact forward. We need you, and we look forward to working with you on this. And I want to just close with, we all know this, but applause is not enough. Clapping was great. It doesn't pay the bills. It doesn't protect our health and care workers. It doesn't invest in their futures. So let's look to how we can show our gratitude better. Now I'm stopping. Thank you so much.
Thank you so much, Katherine, for that excellent presentation and for keeping in time. Okay, so we have some time for Q&A. Let me now turn to our speakers and ask them a few questions. You've been active on the Q&A chat, so I'm going to pick and choose. So the first question is for Dr. Assaghid. And one of our participants wants to know, what is the composition of healthcare workers in health posts and health centers? How much do these healthcare workers get trained in the competencies for delivering high quality primary health care? Dr. Assaghid.
Yeah, thanks so much. Thank you for raising this important question. So regarding the composition of the PHC workforce in our context, actually, I just replied to the person asking this question. So we will just, disclose the exact figures, for this group via email. But, talking about, the competence of the specific competency that the PHC workforce needs to be trained to avail, quality health service in PHC system is a critical question. For that to happen, specifically in our PHC system, the competencies, the services are already identified. We know what type of services are needs to be delivered in our PHC system. For that to happen, and for the realization of these services, we have also, identified the competencies that needs to be given for our healthcare workers. For this issue, we have actually worked with Ministry of Education that the identified competencies that needs to be trained for our PHC workforce, which helps them to avail service after graduation. For those who are already in service, we have designed a continuing professional development and in-service training systems, which helps them, to have adequate knowledge, skill, so that they can avail, quality PHC services. So we are working in this regard, but specifically on the number, I think I will disclose the exact figure later. Thank you so much.
Thank you, Dr. Assaghid. Katherine, so when you started your presentation, you talked about the lack of women in the managerial positions in the health workforce, and this is clearly a very important issue. I was wondering if you could speak a bit more about that. Do you find this, for example, much more in certain parts of the world, or is it something that is universally seen across the world?
This is globally. There's no question that we see this in so many places. I wish I could come up with the exact statistic, but in fact, if you look at the number of people named John who are heads of Fortune 500 companies, they exceed the number, it isn't Fortune 500, but there's an annual note that counts the number of Michaels or Johns in my country who are heads of companies. And those are more than the number of women. Just one name. This is globally. No, there are very few countries, in fact, that do have this kind of representation. But you see within the policies where a gender transformative policy actually does contribute to building strong health and care workforces. It contributes to so many elements, but focusing simply on the health and care workforce, women are able to bring in unique perspectives and unique approaches. And instead of being threatened by those who are different or feeling like one is being squelched, it's really an opportunity for everybody to join hands and look to where each different person, each different occupational group, each different gender or self-identification brings in new perspectives that improves health services. Health workers don't go into the professions just to have a job. They do it because they have a passion for serving people. And the best way that we can do this is by understanding those needs, reflecting those needs in the composition of our workforce, and leveraging all of those complementary strengths.
Thank you, Katherine. So now, Dr. Assaghith, another participant is asking regarding the role of community in primary healthcare HRH planning in Ethiopia and its implementation. Can you speak a bit about this? Thank you.
Thank you so much again. I think one of the basic aspects of health service delivery is engaging, the community. It's only when we engage the community at adequate level that we can ensure a resiliency and sustainability of our healthcare delivery system. So for that to happen, the contribution and the role of the community is very high. In our health extension program, the aim was, to provide adequate knowledge, skill to the community so that the community will be able to produce their own health. That was, the issue. So for this to happen, the community needs to be, highly active to engage in a healthcare delivery system. They need to question, the healthcare system, how they can ensure quality of the services. If there are, issues regarding, quality issues, they can raise questions or they can, ask through the platform that the government set as a structure so that they can ensure quality of the health services in our system. So the community have, a different, I can say well-defined role, but we expect the community to be engaged in the healthcare delivery system in an adequate space. That's what we expect from our community, and their engagement is also very much appreciable. We hope the community will be engaged further so as to ensure quality and resiliency of our healthcare delivery system. Thank you so much.
Thank you, Dr. Assaghith. And now my last question is for both of you, but I'll first ask Katherine. So in the presentation Dr. Assaghith made, he talked about the importance of investing in the motivation of health workers. And clearly, this is also a very important issue. From your perspective, Katherine, what can be done to increase motivation of primary healthcare workers from the experience of WHO and your own position? Thank you.
This is a really intriguing question because one of the most important elements of our agenda is decent work. And there are a number of different pieces of evidence looking at what motivates health workers. In fact, we had a webinar on intrinsic motivation of health workers recently, and there were some very interesting polling results within those. So number one, fair pay, come on. Would you work for a t-shirt? Why do we expect people who have nothing to work for a t-shirt, to work for their community? So let's look at basic motivation, decent working conditions. What motivates health and care workers? The ability to provide good services. And this is done by having effective supportive supervision. None of us is perfect on our own. None of us is going to retain everything that we've learned, but with supportive supervision, we're able to be our best selves. We're motivated to come to work, and we're motivated to keep improving our knowledge and capability. What else? Good management, safety in the workplace. The opportunity to look at career advancement, if that is something that is particular to the individual. Not every individual wants to advance. Some individuals want to do one job, but many do. And so ensuring that there are steps available that they can take additional education and training courses. But that supportive work environment, that decent work agenda, that opportunity is what motivates health workers. And we have any number of studies that we will be sharing more throughout the year. It's not just pay, but pay is part of it. Let's make sure that we are supporting people so that they can support their families, so that their families can support them and their communities can thrive with health workers within.
Thank you. We have a minute left. And so, Dr. Assegid, can you quickly tell us about what Ethiopia is doing in particular to improve motivation among primary healthcare workers? Thank you.
Thank you so much. I think this is also a very important question. So at the country, we believe that motivation and retention are very important, to help organizations attain organizational efficiency on one hand, by increasing the productivity and profitability, while on the other hand, it satisfies the individual needs of employees, by reducing stress, job insecurity, and increasing loyalty, commitment, and so on. This is, the truth that we believe. For this to happen, we are doing, lots of things. The first one, we have developed or designed a policy, a motivation scheme, which will help to address, majority of the PHC workforce. Is on progress. We hope the government will endorse this document, and this is one of the things we are doing. Beside, that one, sometimes it is very difficult to say a single way will motivate all healthcare providers. Sometimes, the motivation might vary from, professional to professional, from person to person. But for that to happen, we are also working to design non-monetary way of, motivating our healthcare workers. As already explained earlier, we need to have, a decent workplace. We can make our workplace comfortable, to our daily routines. We can make that. This kind of issues help us to motivate our healthcare workers. So this is one of the things we are planning further to promote in our healthcare facilities, in our PHC system, the education, because we need to design a defined career structure. We need to have a promotion strategies. We are working on that regard. The recognition of health workforce is very important. Last year we have made a national-wide recognition for healthcare workers who committed their everything, I can say, their life, their family, everything to combat the COVID-19 and other emergencies. We have made a national recognition. Similar way of recognition is cascaded to all healthcare facilities. This help us to motivate the health workforce, but these are not the only things or the only way that we can motivate our PHC health workforce. but we are also, thinking, trying to design different modalities so as to motivate our health workforce and further retain in their regular workplaces. Thank you so much.
Okay, with that, I want to thank both our speakers, Dr. Asagid Samuel and Dr. Katherine Kane. It was a great presentation, and looking forward to more such presentations in the future. Thank you all for joining us, and wish you a good week ahead. Thank you very much. Bye.
Thank you so much.
Thank you, everyone, for joining us. Stay tuned for our upcoming webinar that will be focusing on most of the topics that you guys have been raising, which is around gendered PHC. We have heard about it, and we'll be having that webinar in end of February. So stay tuned and spread the word. And thank you, everyone, both our collaborators, Johns Hopkins University School of Public Health, Bloomberg, and our speakers for being here. And thank you for your active participation from our participants. Have a wonderful morning, day, evening. Thank you. Bye.
Thank you so much.